The rehab and physical therapy and you as the patient are doing the vast majority of the work. And then I can come in with injections occasionally and just kind of help bump things along or kind of guide in the right direction. All right, welcome back, everybody, to the third season of the Building Lifelong Athletes podcast. I'm your host, Jordan Rennicke. Thanks so much for stopping by. Really appreciate it here. So we've talked about a couple previous seasons. Now we have a new season coming up here. This whole season, we'll be talking about injections. So as a sports medicine doctor, I do a lot of various injections, and I kind of want to walk you through all about various injections. So, the first one we're going to talk about today is essentially when to consider injection. We're going to have lots of ones coming in the future here, but the first and foremost is, hey, who is a good candidate for having an injection, right? Not everyone's going to get an injection, and I don't recommend that for anybody. I'm pretty judicious on the injections I do give, and so it's definitely not for everybody. I'm not a person who's going to be like, oh, everyone should get an injection. That's fine. No, but today we're going to talk about, when should you consider getting an injection? So when we first start off and do that, the first thing I kind of talk about, I'll kind of go the opposite and say, when do you not get an injection? Most things being, common, I'd say we do not get an injection immediately after being injured, right? Like unless you're a professional athlete, that might be different. And like I said, all the rules go out the window for professional athlete. And we know that if you're a professional athlete, then, it's not the most healthy thing in the world to be playing that high level and you're gonna have issues. And so that being said, this is for our everyday athlete here. Is that, we are not going to have an injection right after you get injured. That's typically not what we want to do in terms of, you had a strain or something simple like that, an injection right after, usually not necessary at all, right? It's just going to cost you money, time, and there's always potential side effects, which we'll talk about later. But that being said, it's something that I would say if you have an initial injury, like we are not going to start that right away. So, and like I said, also another time we're not going to do injections if you've done no therapy whatsoever, or you don't plan on doing any sort of rehab whatsoever. This is another instance here where if you have not done any like physical therapy, any rehabilitation, and have no plan on doing that, then I typically won't do an injection. Obviously, there are exceptions to this. If someone's like 85 and they have bad arthritis and they're just trying to have improved quality of life, that's a whole different conversation. But for most people, who are younger and are active and can move around and can do rehab, for me, I always ask them, if you are not planning on doing any sort of rehab, like for me, then injection is probably not ideal, right? If you think about an injection is a lot of times like a Band-Aid, potentially. If we inject some sort of anti-inflammatory medication, it's going to make you feel good for a little bit of time. But then if we don't get to the underlying problem of what's causing that issue, then injection is not going to do much because it's just going to come back in, a couple of days, weeks, months, however long the injection lasts. And so that's another reason that I wouldn't do an injection on someone if they have no plan on doing therapy, unless there's certain circumstances. But like I said, if I'm envisioning the, general weekend warrior, someone who is active, who wants to be active, and they say, oh, I just don't have time for therapy, I just want an injection. Like that's not a good reason to get an injection personally. In my experience, I haven't had a good success with doing that. And so I'll typically talk with patients and kind of counsel them there. So and then also another reason I will not give an injection is if you haven't had your treatment options explained to you, right? So this is not like I'm stopping you, but you might not understand all the options. A lot of times some people I've seen in the healthcare world where they saw their primary doctor and they got referred to me and they come to sports and they're told they need an injection. They're like, oh, I was told I need an injection. And I was like, oh, why do you need an injection? Do you want an injection? They're just like, I hate needles, but this is what they said I needed. And so I get to have that conversation with them. And that's my job as a specialist, as a sports medicine doctor. I get to have these conversations and talk about the risks, benefits, and all that fun stuff. But like I said, if you haven't heard all your treatment options, then it's not a great place to start. I usually don't jump right to there. In terms of treatment modalities, like I said, I'm pretty darn regular in terms of the first thing. If you have a pyramid of what treatments are, the first thing in the bottom is going to be rehab in terms of some sort of physical rehab, whether that's physical therapy, at home exercises, something like that. That's going to be the base of that pyramid, and then we'll move up to maybe injections and then surgeries if we need to and stuff. But like I said, I usually don't jump right to injections. And so also, if you haven't been explained what your options are, then it's not fair to just come in and do an injection. I know it can be done. And people do it where they come to a physician and right away they do an injection. And so that's just not how I practice typically. And so for me, this is kind of how my practice and what usually works well for me. So things to consider. Now I want to talk about when do you consider an injection, right? So we talked about people who are not good candidates. So people who, got hurt in just a really acute injury. It's not ideal. People who don't want to do any sort of work in terms of therapy or haven't had their options explained to them. So those are when I wouldn't want to recommend it. And then now let's talk about when we do consider it. The first things first is you're in pain, right? Most of the time people are getting injections when they have pain. I have seen some weird things on the internet where people get injections just for fun of random stuff. And for me, that's not necessary. But first things first is if you're in pain and not feeling well, that's the main reason people come and find me and talk to me. But that's a good reason why I think it's a very reasonable reason to have for why we consider consider an injection. Another reason I talk about is when people have stalled out with therapy, right? So like I said, on that pyramid I talked about before, the base is physical therapy, right? So if you've been doing that, religiously for a couple of months and we're still not getting any improvement, well, then I think it's reasonable to consider getting an injection, right? That's kind of my whole thing is like, I kind of talk about an analogy when I counsel patients on the risks and benefits, all that stuff. I say, if you live in the north, I use a snow example. If you live in the south, I use the mud. But I'm from the north, so if I say if you're stuck in the snow, right, and you're just spinning your wheels, you have a buddy come over and they push you out. It's that nudge that gets you going, right? And then, but reality, the car spinning the wheel, that's what's providing all the power. Once you get that push, then you can make it out. I always say the injections are like your friend pushing that car, but the rehab and physical therapy is like the actual car itself. The rehab and physical therapy and you as the patient are doing the vast majority of the work. And then I can come in with injections occasionally and just kind of help bump things along or kind of guide in the right direction. That's how I view almost all of my injections, is that I'm just trying to be a guide and trying to help you get back and facilitate you to rehab so you can do more. Like I said, sometimes you just need a little bit more to get over the hump, and that's a reasonable thing to do as well. And so I said, going hand in hand with that as well, you'll see that all these things I talk about, we're doing therapy, we're taking time. So like I said, a good candidate also is someone who's had this for a while. And like I said, you might be like, oh, that's mean, Jordan, to let people suffer for a while. Like, first of all, I'll never let someone suffer. If something's really bad or going on, like there are options we can consider, and that's a whole different conversation, different podcast. But the vast majority of people who already worked through me have gone through, saw in their primary and then came to me, and maybe they did some therapy, maybe not. But like for me, my job is to decide, hey, have we done a really good rehab? Have we been, kind of off base? Have we been doing just a bunch of passive modalities in terms of stretching and stim or whatever? And so kind of determining, did we actually give true physical therapy and progressive overload a try or not? And so like I said, I'm going to have those conversations with people. That's my job, and we'll do that. But like I said, usually it's a chronic injury, something that's been going on for a while, and someone who's willing to put in the work. So that's kind of like my ideal avatar of person who hey, you're a good candidate for injection. And when it comes to injections, we have a bunch of different options. Like I said, we're going to have more on these in the future podcasts. I'm going to break down pretty much each one of these injections and talk more about it. But in general, the main injections that we'll have are steroid injections, NSAIDs or anti-inflammatory medications, hyaluronic acid or viscosupplementation, they sometimes call it, dextrose prolotherapy, PRP, and stem cells. So those are kind of the big ones. And we'll talk all about those. I would say the vast majority of injections most people think about are steroid injections. And when I mean steroid, I don't mean anabolic steroids like you see in the bodybuilding community. Not like that. They're not the ones that'll make you jack. There's a different type of steroids, things we take when people have flares for arthritis and stuff like that. So definitely not a anabolic steroid, but those are the main ones, and we'll talk about each one of those and break those up into individual episodes, and we'll talk all about this so we can understand, who to use these on, when they're a good idea. And then another question people ask is well, who should I see for an injection? Well, there's a bunch of different providers that you could see for an injection. First things first, obviously everyone thinks of orthopedic surgeons, that they can do injections, and they can for sure, because they can do surgery. I mean, if they can do surgery, they can do injections, right? And yes, they can, absolutely. There's also non-operative sports medicine physicians. That's where I fall into. So I'm someone who's a fellowship in family medicine and in sports medicine. So primary care sports medicine. So I did my family medicine residency and then sports medicine fellowship. So I'm a non-operative sports medicine. And then also some primary care doctors do things. Sometimes they'll do more basic injections like a subacromial shoulder injection or a knee injection. And like I said, all those things, those two things can be done by a lot of primary care doctors, which can be helpful. But I said, those are the different kind of levels for most injections. Say I'm obviously very biased because I am a non-operative sports medicine doctor. And I would say, I think preferred would be a sports medicine doctor who's trained in ultrasound skills. So at the end of the day, what we can do when we're, trained in ultrasound is we can actually look and see the pathology. We can see the knee joint, we can see the tendon, we can see whatever, and then we can see the needle going in real time, so we know where we need to be. Like I said, and that's a big thing, is we can actually visualize our needle, so we know the medication is getting right where it should be, as opposed to a lot of times other physicians will do blind injections. Blind meaning not like they close their eyes and just guess, but blind meaning they're just going based off of landmarks, which can be accurate at times. There's some good data that orthopedic surgeons really know where the knee joint is. No surprise, they're doing surgery all day and putting scopes in there, so they know where the knee joint is. But then when they compare shoulder, they say that ultrasound guided is more specific and have a higher chance of getting the medication where it needs to be when compared to just landmark. And so for me, if you can do it with an ultrasound, I typically do it with an ultrasound. There are some that are pretty straightforward enough where we don't necessarily need an ultrasound. Like I said, a lot of times knees and subacromials don't necessarily need them. And so that can happen. But like I said, most of the time I'm using the ultrasound on anything that's a little more complicated. I'd recommend, finding someone who can have ultrasound skills to do that. There are also, I just not to be confused, physical therapists can do dry needling. And so dry needling, most people think, oh, that's an injection. It's not really an injection. It's just actually using the needle itself. And so they're not injecting any sort of medication in there. They can't do that. And so that's just something I do mention as well. And then kind of going back, I just want to talk about landmark versus ultrasound guided. So I mentioned, finding someone who does ultrasound guide injection. Typically, like I said, these are going to be our non-operative sports docs. It can be orthopedic surgeons as well. I have seen some use them, but a lot of times, like I said, they do surgery and they don't necessarily do as many ultrasound guide injections, but it can happen. But in most situations, ultrasound guide injection is going to be better in, like I said, almost every situation. There's not a lot of times where I think doing landmark is better. And so you don't necessarily need to use an ultrasound, but you're greatly improving your chances of getting medication where it should be. And so that's what I said. So even, like I said, mentioning again, studies have shown that even orthopedic surgeons can sometimes struggle in joints that aren't the knee. So like shoulders and stuff, like I said. So anything that's not super basic, I think it's recommended to use an ultrasound. I think it'd be good. And the people who will do that, like I said, non-operative sports docs, this can be, physicians who train in family medicine, pediatrics, emergency medicine, or PM&R. And all those people can then do a fellowship and get ultrasound guided injection. PM&R, a lot of times those docs don't even necessarily have to go through a fellowship. They do a lot of ultrasound training during their residency. And so that's something to think about as well. But like I said, what you'd be searching for is a primary care sports medicine doctor or someone who has sports medicine fellowship. So it'd be CAQSM, which means, a certificate of additional qualification in sports medicine. If you Google that, that's someone who can most likely do ultrasound guided injections. And then when considering an injection, you always have to consider price, right? Some injections are crazy expensive. Things like PRP and stem cells, unbelievably expensive. And a lot of times these higher ones are not covered by insurance. Other ones, thinking like steroids, hyaluronic acid, those are kind of anti-inflammatories. Oh, those things are kind of a little more common, and usually they're covered by insurance. And so like I said, if someone's, shelling out PRP or stem cells or, talking about those injections, the odds are it's not going to be covered by insurance. PRP, there's starting to be some procedures that are covered by insurance, but not a whole lot. It's looking like potentially knee osteoarthritis or lateral epicondylopathy. Those are kind of the two that are kind of making their way there. But like I said, a lot of times PRP and stem cells are going to be not covered by insurance, and they can be crazy expensive, like, $1,000 for PRP, $3,000 plus for stem cells. So an insane amount for these injections. And we'll talk more about those later. But like I said, that's just kind of giving you the basis. But otherwise, ones that will be covered by insurance, usually steroid, hyaluronic acid, NSAID like ketorolac, that can typically be there. Dextrose prolotherapy kind of falls in between. Some get covered, some do not. So I want to mention that as well. That may or may not be covered. And so anytime I talk to someone about having an injection, I always have to talk about the risks, benefits, and alternatives, right? So you have to be a well-informed patient. I think it's their right to know what could happen in any sort of injection. So I always talk about risks first. The biggest risk we always worry about is infection, right? If I'm bringing a needle into the joint, I'm taking something from outside the skin and putting it underneath the skin, meaning the needle's coming out in, and we try to clean it as perfect, as good as possible, but there's, it's not a sterile field entirely. It's not like surgery. So there's always a chance that something from outside can get inside. The risk of what we call septic arthritis, which means a big infection in the joint that's kind of scary in an emergency, when you need like a washout in surgery, the odds of that happening are exceedingly rare, like about 1 in 10,000 plus, depending on which study you look at. So pretty darn rare. But like I said, this is the one I always counsel patients on, saying, hey, if over the next couple of days you start to develop a joint, let's say your knee, it starts to get red, hot, swollen, maybe start getting fevers, and the pain starts getting out of control, like that is not a normal reaction to an injection. So that is what we look out for a septic joint. And so we would want to go to the ER. That's an emergency. So like I said, that's the biggest thing I always counsel about. And it can happen, but like I said, exceedingly rare, but it is on the list. And I always have to tell everybody that's a possibility. Then another thing I always talk about is pain, right? Unfortunately, a needle is a needle, and I found no way to make a needle not feel like a needle. Like they have some of the cold spray, which can be helpful as well, but like I said, it's still a needle. Usually they're pretty small. In terms of gauges are anywhere from 25 to 18, and 18 is a decently big needle. That would hurt. 25 is pretty small, and so usually people tolerate that really, really well, but sometimes it can be painful, especially if you're going somewhere sensitive like the hand or the foot. That can be bad. Another risk is you could have some excess bleeding. Like I said, there's a lot of small blood vessels in a lot of injection sites we do. Usually not a lot of big ones, but there's always a chance that, you're going somewhere and there's a big blood vessel, or there's a blood vessel where you didn't think there would be. So there is a chance of bleeding as well. Most of the time, if we do have additional bleeding, it's usually from a small blood vessel. Just put a little pressure on there and that's all you need. But like I said, that can happen. And then I also tell them it's possible to have damage to a nearby structure. Nearby structure meaning, hey, maybe there's some branch of a nerve we're not sure of. Maybe your anatomy is a little different and we could hit a nerve, or like I said, hit a small artery that we don't know about. That's always an option when doing an injection. And even on the ultrasound, even if you use the ultrasound, and there's some very small nerves, you wouldn't necessarily see them in ultrasound, so it's possible to get that. I say if we hit it, you might feel a zinger. Like I said, there's some pretty much experienced people say that if you readjust and move, like a lot of times it gets better and most of the time that recovers fully. But there's always a chance, right, that we hit a nerve with the needle and it leads to lasting damage. That's just the way it works. Like I said, it's very rare for that to happen, but it's always something we have to consider. And like I said, I always talk about these risks and like not to try to scare people, but just so they understand like, hey, we're doing an invasive procedure, that something could happen. And that's why I take it so seriously that when we do an injection, I make sure it's the right person, because all those things could happen. They don't happen very often, but it's always a possibility. So I want to make sure. Then I always talk about, the benefits, right? So I've talked about risks, benefits. Well, hopefully they're an improvement in your pain and function. That's the ultimate goal, is getting you out of pain and helping your function, like I said. And to me, it's not an idea to just say, hey, this is just get rid of your pain. Because like I said, a lot of times they're temporary. They're not going to necessarily get you better. I want to get your pain better so that we can help your function get better. That's what I go for. And then I always talk about the alternatives, right? So what are our alternatives to injections? Well, do what you're continually doing, which is either nothing or physical therapy, or another alternative would be potentially surgical options for some things. And so that being said, that's always, we kind of escalate things as needed. But like I said, we just talk about risks, benefits, alternatives, and it's always a patient's choice. To me, I kind of just give you information and you kind of let me know, hey, is this something I want to do? Is it not what I want to do? So I always put this in the patient's hand. And obviously we work on it together. We're a team when we decide something like that. Say, hey, this is what I think, this is what I do. And that can kind of help patient decide like, hey, I give you this information, I can kind of help make sense of it. And hopefully you have a good understanding of, the condition you have, the treatment options, and what an injection might offer. And so that's kind of how I work through this. And at the end here, I just want to talk about my perfect injection candidate, right? So I've kind of talked about before, my perfect injection candidate is someone who has a chronic issue, right? Hasn't been there right away, has given a little bit of time, has been working hard on rehab and therapy, and maybe they've just stalled out with therapy, right? They've been doing, really good work, trying hard, but they just can't quite get there. That's the person I'm looking for. And then also they have to understand, the injection is not going to heal them. It's most likely going to help facilitate them to help your body heal it, but it's not necessarily going to heal them. And they have to be willing to put in the work. They have to understand the risks and benefits, and they also want to try the least amount of intervention possible and then progress from there. It's like, those are my perfect people, meaning like, hey, this is ideal. And obviously I do injections all the time on people who are less than ideal, because that's the real world, right? Things are never that cut and dry. They're like, oh, Dr. Rennicke, I've tried this, and we go there. That's just not how it works. But like I said, that's my idea in my brain, and the general framework is what I want. Someone who's been going for a while, really has been working hard, wants to work hard, wants to do the least amount of invasive procedures possible, and then kind of go from there. So that's like, I think, ideal. And that being said, that is not the only person who's going to get injection from me. There are other cases that I'm going to, like I said, that I will give on a case-by-case basis, and we'll do that. But like I said, that's what I think about walking into it. Like, that's my ideal. And then everyone's different, right? I'm here to help people as much as I can. And I'm not going to say like, this is my way or the highway. Like I said, this is usually how I think about it, how I go through that algorithm of like, hey, who's a good candidate and whatnot. But like I said, that is what I want to just share today. If you're thinking of getting an injection, I hope you kind of walk through this and say, hey, maybe that sounds like me, I'd be a good candidate for it. Or maybe, okay, I didn't realize that. Maybe it's not ideal. And as you listen to this whole, series and this whole season, we're gonna talk more and more about like when we should be getting injections, for what conditions, what are the success rates of them, all that stuff. We're gonna go deep dive in on all that stuff. So thank you so much for joining me today. I really appreciate it. If you could like, comment, subscribe, or share with a friend, that would mean the world to me. Also, additionally, I have a newsletter that's starting up. And if you want some short, real summaries of some literature that I'm reading through the week, I'll send it out to you. It'd be very helpful. And I think you might enjoy that. But like I said, if you've enjoyed this, it means the world if you could share it with someone. Now get off your computer, live your life, and go have a great rest of your day. Thanks for tuning in. We'll see you next time.